So what is diabetes? The burden and complexity of the diabetes. This picture can depict it. It's a very complex disease with a lot of complications, and it has a lot of burden. It has put a lot of burden on our society. You can see that. So what is diabetes? Diabetes mellitus is a chronic condition that is characterized by raised blood glucose level, which is also called hyperglycemia. So a condition which causes increased glucose is called diabetes mellitus. How is regulation of plasma glucose level done? It is a tightly regulated procedure. It by means of hormones. The main hormone which causes the decrease in levels is the plasma glucose is insulin, and those which causes increases the glucose levels are glucagon, epinephrine, cortisol, and the growth hormone. So only one hormone is responsible for down regulating the glucose levels, and that is insulin. And how does it do it? It does it by having a negative effect on the glucagon, so decreases the release of the glucagon, and it causes uptake of increased glucose uptake by the muscles and by adipose tissue. It also affects the liver and decreases the glucose production. So whenever there is high blood glucose level, pancreas will cause the release of the insulin, which will inhibit glucagon and which will tell the liver to stop producing the glucose, while on the other hand will ask the muscles and adipose tissue to take up the glucose, and this in turn will reduce the blood glucose levels. Classification of diabetes. So diabetes is classified mainly as type 1 diabetes or type 2 diabetes. Type 1 diabetes was formerly called as insulin dependent diabetes and juvenile onset diabetes, which was because it was considered to be a diabetes of younger age group of children, but now the concept has changed. Number 2, the type 2 is diabetes, which is a combination of insulin resistance with relative deficiency in insulin secretion. So there is resistance to the effect of the insulin, and which is followed by the loss of insulin production. So it was type 2, or in Roman 2 was given to it. Then it was previously, before that, was the name was given to it was non-insulin dependent diabetes mellitus, because it was the one which was being treated by the oral hypoglycemic drugs at that time. Or it was initially, in the very beginning, it was named as adult onset diabetes, because it was thought that it was the disease of the adults. But now with the obesity pandemic, we know that that type 2 diabetes can be seen in younger children, in children as young as 2 to 3 years old. Then we have gestational diabetes, which develops in some cases of pregnancy and disappears after pregnancy. Then there are other types like secondary DM because of the chronic pancreatitis or acute pancreatitis or surgical procedures, and there's damage to the pancreas. So we have secondary DM or infiltration of the pancreas, because like in hemochromatosis. Or there is LADA and MODY. The LADA is latent autoimmune diabetes of adults, and MODY is majority onset diabetes of young. We are not going through them right now, and I will talk about them in my next lecture, which will be about the diabetes complications, and I will also touch these three over there, the gestational diabetes, LADA, and MODY in that lecture. So what is the etiology of type 1 diabetes? Type 1 diabetes is an autoimmune disease which causes selective destruction of the beta cells by T cells. There are several antibodies which are acting against these beta cells, and these antibodies are like islet cell antibodies and anti-insulin antibodies, anti-GRAD antibodies. These are the antibodies which are in the body, and they affect them and causes the destruction of the beta cells. What exactly is the cause of this autoimmune attack? We don't know. Both genetic and environmental factors can play a very important role. So what can be the environmental factor? Many viruses have been considered as cause of this, like Coxsackie virus, mumps, and rubella. while like cow milk and nutrients is the cow milk which is being considered producing the antibodies. So babies, when you start giving them cow milk, they develop antibodies to cow insulin, and this insulin then with these antibodies then they start acting against the human insulin. So cow insulin is similar to human insulin, and then this results in attacking the beta cells. So that's how it happens. Type 2 diabetes is one because of the impaired insulin. So type 2 diabetes is a different entity. What happens is, in basically what is the cause of type 2 diabetes is that the insulin is being produced but it is not being effectively used by the body. So there is impaired insulin action, because of which there is decreased utilization of the glucose by the muscles and the adipose tissue, and there is increased glucose production by the liver. So this is because of the impaired insulin. The body keeps on producing the insulin, and it keeps on producing, and there are high levels of insulin, and due to excessive production of the insulin, the beta cells, they get exhaust, and there's dysfunction of the beta cells, or death of the beta cells takes place, and then there is impaired insulin secretion in patients. They move toward complete deficiency of the insulin, from higher level of insulin to complete deficiency of insulin in type 2 diabetes. Mechanism of hyperglycemia. So how does hyperglycemia occurs in diabetes? In absolute, there is, or type 1 diabetes, or in relative type 2 diabetes, when there is insulin deficiency, there is increase in hepatic glucose output and a decrease in peripheral glucose uptake and utilization. So the muscles and adipose tissue cannot take it up, and the liver keeps on producing it. So decreased insulin will cause decreased inhibitory effect on glucagon secretion, thus increase glucagon, and this increase in glucagon, it will in turn act on the liver, causing gluconeogenesis and glycogenolysis, which both will result in increase the plasma glucose level. So one way of having hyperglycemia is increased production of hepatic glucose under the influence of glucagon. Then there is decreased uptake, because if insulin is not there, muscles will not be able to take the glucose up. So decreased glucose and amino acid uptake and increased protein breakdown will lead to increased plasma glucose and plasma amino acids. So the glucose is not being taken up, so that's causing increased level of plasma glucose. The proteins are broken down, so this leads to increased plasma amino acids. Adipose tissue, decrease insulin, increase lipolysis, decrease lipogenolysis, and increase plasma fatty acid levels. So ketoacidosis, which takes place, is because of that insulin deficiency. So what is the characteristics of type 1 and type 2 diabetes in different scenarios? We have percentage of diabetic population, only 5 to 10% have type 1 diabetes, more than around 90% people have type 2 diabetes. Age of onset in type 1 is usually younger age group, less than 30 years, and in some adults, that is the LADA, which appears in the adults. And type 2, it is usually above the age of 40, and in case of the obese children. We also have another entity known as double obesity, double diabetes. It is a condition in which children who have type 1 diabetes, but because of their family dynamics, they put on weight, and as they put on weight, they develop type 2 diabetes as well. So the new category of double diabetes is also coming in. Pancreatic function usually is none in type 1, and it's in type 2 insulin is low, normal, or high. So it all depends on the stage of the type 2 diabetes. Pathogenesis, it is an autoimmune process in case of type 1. In type 2, it's the defective insulin secretion, or there's tissue resistance, so increased hepatic glucose outcome. So that there are many mechanisms in type 2. His family history is not strong in type 1, it is very strong in type 2. Obesity is not in common in type 1. Usually type 1 have weight loss, severe weight loss. Obesity is a common presenting feature of type 2 diabetic patients. History of ketoacidosis is often present. Type 1 diabetics mostly present with ketoacidosis. A young boy, a young girl for the first time at the age of 13 or 14 will be coming to ER with abdominal pain, and there will be ketoacidosis on investigations, and then the sugars will be checked, they will be very high. Very first presentation of these patients is ketoacidosis. Most of these patients in type 2 rarely except in stress or at the end when the type 2 reaches to the burnout stage, when the pancreas is completely burned out. That is the point when type 2 patients, they also start having ketoacidosis. So older age groups of type 2, we see very commonly ketoacidosis in them. Clinical presentation in type 1 is usually moderate to severe symptoms. The polydipsia, polyuria, polyphagia, the 3 P's are there: fatigue, weight loss, and ketoacidosis. While in type 2, the symptoms are mild. It is polyuria and fatigue, and diagnosis is on routine physical examination. Treatment: type 1, insulin, insulin, insulin. There is no other treatment besides insulin. You have to replace insulin in these patients, and then you do the diet and the exercise. In type 2, diet and exercise is the first thing. You have to make them lose their weight. Some people who are at the border of it, they will be just little higher levels, just having the 6.5 HbA1c. That's the cutoffs of the type 2 diabetes will improve with diet and exercise. And then the oral antidiabetics, insulin, and then newer anti-diabetic modalities. There are many. We have the diabetes in the field of diabetes, the pharmacy, the therapeutics has boomed in the last few years, and there are many drugs to be talked about. So in epidemiology, it is, as I said, type 1 is due to pancreatic islet cell B cell destruction, predominantly by autoimmune process, develops in childhood or early adulthood. 10% of all diabetic patients, and as a result of exposure to genetically susceptible individuals to environmental agents. So एक genetically उसमें problem थी, और फिर कोई environmental agent, कोई virus आके लगा उसको, और उसकी वजह से उसकी susceptibility थी पहले से, और उसको exposure हुआ, और उसको type 1 diabetes की antibodies बनी, और वो destruction start हो गई. Type 2, it results from insulin resistance with a defect in compensatory insulin secretion. Insulin may be low, normal, or high. 30% of type 2 diabetic patients are undiagnosed. They don't know that they have disease because they're mild. 90% of all cases of diabetes are type 2 diabetes. Risk factors: genetic predisposition in type 1, and then virus or toxin exposures can lead to this. In type 2, family history important, obesity, physical inactivity, previously identified if they're impaired glucose tolerance or impaired fasting glucose. So then there is a chance they are at high risk. If there is hypertension and hyperlipidemia, then there is high risk of having type 2 diabetes. So how carbohydrate metabolism takes place? Carbohydrates are metabolized in the body to glucose, and this glucose is then used up by CNS. Our brain uses the glucose, and this uptake by the brain is independent of insulin. It doesn't require insulin for that. Glucose is also taken up by muscles to produce energy, and muscles need insulin to do that. Glucose is stored in liver as glycogen and in adipose tissue as fat. Insulin is produced and stored by the beta cells of the pancreas. So what happens after the food is ingested? Blood glucose concentration rises, which stimulates the insulin release. Insulin in turn causes the increased glucose uptake by the tissues, increases glycogen formation, decreases the glycogen breakdown, increases lipid synthesis, and inhibit fatty acid breakdown to ketone body, promotes protein synthesis. In turn, the glucose levels of the blood glucose levels, they start falling. What happens in the fasting state? In fasting state, insulin release is inhibited. So your body doesn't have your body realizes that there is no more glucose in the blood. So the blood glucose, when as it starts falling, then the insulin release is inhibited, and hormones that produce the hormones which are responsible for increased production of the glucose in the blood, they are released from the body, like glucagon, epinephrine, growth hormone, glucocorticoids, thyroid hormone. There is glycogenolysis, so whatever glycogen was stored, it starts coming out of there, and it starts breaking down and it is converted into glucose. Gluconeogenesis, amino acids are transported from muscles to liver and they are converted to glucose. Triglycerides are broken down into free fatty acids as an alternative fuel source. So when you don't have glucose, the free fatty acids are used, and triglycerides are the ones which are broken down for it. So again, the same thing. Type 1 is absolute deficiency of insulin due to immune mediated destruction. In rare cases, it's not due to immune mediated, it can be called idiopathic. So we can see in this picture this insulin producing cells, the blood cells, the insulin is being produced in the cells. These beta cells, they are quite nicely arranged around the arteries, and they are capillaries, and they are producing the insulin. Over here, there's destruction of the insulin producing cells, and so no insulin is there in the blood. There are 4 stages in the development of type 1. Preclinical period with positive beta cell antibodies. There's just beta cell antibodies, they don't have symptoms. Then when 80 to 90% of beta cells are destroyed, we get a hyperglycemia phase. Then there is a transient remission where patients, they go into remission and they start producing a little bit of insulin which they have, that starts working, and this is known as honeymoon phase. And after that, the 4th stage is the establishment of the diabetes. So we can see this is the beta cell mass, which is 100% at the time of the birth, and at time in years as the year passes, because of the genetic predisposition and immunological abnormalities, we start seeing a fall in this mass. It is falling, the mass is falling down, but still the beta mass is going down, but still the normal insulin is being released, and patient remains asymptomatic without any problem. He goes on in life. That is the point. 80 to 90% of when beta cells are gone, then the symptoms start appearing. But after appearing the symptoms for some time, some patients, they develop a honeymoon period. So some kind of reserved beta cells, they start functioning, and then therefore people don't have these symptoms. This can last for a year or two, 6 months or a year or two, and then after this, overt diabetes. So 90% of the mass is lost. So when type 1 diabetics are discovered, when they are presenting with diabetic ketoacidosis or with any symptoms, their 80 to 90% beta cell mass is gone. So they are completely, they'll need the treatment at any cost. They have to be started on treatment. Type 2, presence of both insulin resistance, insensitivity, and some degree of deficiency or beta cell dysfunction. It occurs when a diabetogenic lifestyle, excessive calories and intake is too much, eats too much, inadequate calorie expenditure, meaning no exercise, sedentary lifestyle, and obesity, the weight gain, is superimposed upon a susceptible genotype. So there is a genotype, if it's running in the family, so this gene is over there, and then patient is not having good lifestyle, he is sedentary, he eats a lot of fast food, and he's getting obese, so he will develop type 2 diabetes. So insulin resistance will be there. It develops. Patient initially has obesity, pre-diabetes, diabetes, and then uncontrolled hyperglycemia. So patients start developing insulin resistance, and with this insulin resistance, he starts having macrovascular diseases. So 0 is the point when you have discovered the patient has diabetes, and this is the time when he doesn't know that he has diabetes. So you can see the insulin resistance is still there 5 years before he has been discovered as having diabetes, and he has developed the macrovascular diseases. Beta cell, initially with insulin resistant beta cell failure is not there, they are there, and this starts at the time of diagnosis, they start having the failure of the beta cells. And when there is failure after 15 to 20 to 25 years of having the disease, the insulin level starts declining. That's the time when we start giving them the insulin. And you can see as the beta cell go down, the post-meal glucose start coming up, and it's the fasting glucose which starts coming up a little later than the post-meal ones. And this is the time when microvascular diseases start affecting and developing in these patients. So what are the lab tests? Glucosuria, to detect the glucose in the urine by a paper strip. It's a semi-quantitative and it depends on the normal kidney threshold for glucose. If the kidney has some defect, is already diseased, so then this cannot be much of use. Ketonuria is to detect ketone bodies in urine by a paper strip. It is again a semi-quantitative test. Then the much better to test for ketones is ketonemia, that is the test for ketones in the blood, because there are three types of the ketones which are present in the blood in the body, and the acetoacetic drug is the one which goes into the urine. Beta hydroxybutyrate is the one which remains inside the blood, remains in the blood and is not excreted in the urine. So beta hydroxybutyrate is converted to acetoacid acid, and then sometimes if you don't have ketonuria, if the ketonuria has settled down, you have to check the blood, because the beta hydroxybutyrate might still be there and patient might still be in ketonemia. So ketonuria will tell about ketone, the acetoacetic acid in the or the acetone in the urine. It will not tell you about the true ketone levels. True ketone levels will be detected by doing the blood sample and looking for ketonemia. Fasting blood glucose blood concentration in samples obtained after at least 8 hours of the last meal. So you have to do 8 hours of the last fasting. 8 hours fasting is must for a fasting blood glucose. Random blood glucose is a glucose blood concentration in samples obtained at any time regardless the time of the last meal. So whenever you take the blood, regardless of the last meal. For fasting, it has to be 8 hours of fast. Glucose tolerance test is the most accurate test for glucose utilization, especially in the patients who have borderline levels, fasting levels. What we do is give a 75 gram of glucose to the patient with 300 ml of water after an overnight fast, and samples are drawn at 1, 2, and 3 hours after taking the glucose. HbA1c or glycosylated hemoglobin is formed by condensation of glucose with free amino groups of globin component of hemoglobin. It comprises 4 to 6% of total hemoglobin. Increase in glucose blood concentration increases this hemoglobin fraction. HbA1c reflects the glycemic state during the preceding 8 to 12 weeks or 2 to 3 months. So जो patients कहते हैं ना 3 महीने की शुगर जो चेक करता है टेस्ट, वो ये वाला है HbA1c. Serum fructosamine is formed by glycosylation of serum protein, mainly albumin. And since serum albumin has shorter half-life than hemoglobin, so it is for 2 weeks. Normal is between 1.5 to 2.4 when serum albumin is 5 gram per dl. When is this done? It is done in patients whose hemoglobin level is not appropriate. So someone with anemias, iron deficiency anemia, will have low hemoglobin, so the HbA1c will not be accurate. So their fasting sugars will be high, but they will be having low HbA1c, and we will be misdirected that patient doesn't have diabetes or his diabetes is controlled. In fact, the patient is having anemia. This can be iron deficiency anemia or thalassemia. So in such cases, serum fructosamine helps in follow-up of these patients. So self-monitoring is very important for the patients, because by self-monitoring is the process with which patient will understand his glucose levels, his insulin requirement, his diabetes. He will to know. This is one of the best practices which we have to advise the patients with the diabetes, and they have for strict glycemic control. So it's extremely useful for outpatient monitoring, especially for patients who need tight control. A portable battery-operated device that measures the color intensity produced from adding a drop of blood to the glucose oxidase paper strip. So we have paper strips, glucose oxidase. You might have seen, many of you have diabetic patients at home, your grandparents or your parents, you might have seen this. So you just prick your tip of the finger, put it on the strip, and the strip is then inserted into the glucometer, and the glucometer then measures the level. So this is how it is done. They prick the tip and this. So there are many such, One Touch, Aquacheck, Dex, Prestige, Precision. Many companies are there which are available for this, from which you can get these glucometers. They're very cheap, and we advise most of the patients to have this. Now the newer thing in this is the continuous glucose monitoring. Is a very fancy. There's a patch which has a sensor. It is placed on the forearm. Sorry. So it is placed on the forearm. So it continuously in the subcutaneous. So it continuously measures the glucose level, and it has a fancy this kind of a device with which the sensor uh, transmits. So the sensor transmits the um, readings, and the device tells you. Now what is going on is, now there are several apps which you can download on your mobiles, and these sensors can be connected to those apps, and they will give you a continuous glucose monitoring. These CGMs have revolutionized the glucose monitoring. These can also be connected with the laptops or with the hospital management, and doctors in their hospitals can have a look at the patient's continuous glucose levels and can advise them about their treatment. It is very useful in type 1 diabetic patients or patients who have been put on insulin. So it plays a very